Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami with this afternoon's Instagram chat, Creating a Family for Same-Sex Couples. One of the most important group of patients that we have the privilege of treating over many years have been couples in same-sex relationships and same-sex marriages. And as you know, in order to have a pregnancy establish itself, we need a source of eggs, a source of sperm, and an environment in which the embryo can grow. And this is the same case whether we're dealing with a same-sex couple or a traditional male-female couple. And obviously with modern technology, all three of those don't have to be in the same two people that are in a relationship. So let's break it down in a couple of simple approaches. And the simplest approach, obviously, is if we have a two-women relationship. Excuse me here for a second. If we have two women that want to have a baby together, the thing that's usually missing is the sperm. And one of the women in the couple usually is the one who's wants to be pregnant and carry the pregnancy and give birth. And we've had over the years all different combinations of things. We've gotten one member of the couple pregnant first, and then a couple of years later we use the same sperm donor for the other member of the couple. We've interchanged eggs from the partner to create siblings that have even further identity with the couple as a whole. So whatever works for you is fine. But the simplest approach is if you have two women trying to have a baby, what's missing is the sperm, and we use sperm from a sperm bank. If we're using the woman's, let's say partner A's is going to be carrying the pregnancy. If she has good ovarian function or good ovarian reserve, and even if we need to use fertility drugs, most of the time we're able to achieve a pregnancy with just doing intrauterine insemination with donor sperm. So the simplest approach to a female-female relationship is for one of the individuals who's going to carry the pregnancy to ovulate. And we usually time that with a fertility drug like Clomid, and then in the middle of the cycle inseminate with donor sperm. And that maximizes the chance of pregnancy occurring. The likelihood of a successful outcome in a cycle of treatment would be no different than if the person was having normal relations with a male partner. And it's about 18 to 20% in a young person, and someone over 40 would be about half that. So in general, about 18% pregnancy rates for women under 40 per cycle, and most pregnancies occur in the first 3 to 4 cycles. If a pregnancy doesn't occur within 6 months, then we need to sit down and figure out why it's not occurring. The second possibility is if IVF is done, and that's usually done for one of two reasons. Either A, the couple, if we just call it member A and member B of the female couple, if member A wants to carry the pregnancy but have the egg come from the female partner B, then we can retrieve eggs on the female partner, fertilize it with donor sperm, program the uterus of partner A to be able to implant the embryo and be very successful with that. With IVF, as long as we have good quality embryos at the end of the day to work with, if we put back one normal embryo into a normal uterus, we should see around a 50% or better pregnancy rate. The male side's a little more complicated because we have sperm, but we don't have a source of a uterus. And so in the male side, two people need to be recruited. One is for a source of eggs, the egg donor, and the second is the gestational carrier who will carry the pregnancy. The source of eggs can be either from an egg bank or from a fresh donor. And I think I've talked about fresh donor versus egg bank eggs in a previous Instagram. But in brief, when you get eggs from an egg bank, usually you're getting 6 or 8 eggs, most of the time about 6 eggs. And so the expectation is that you'll end up with one good embryo out of that 6 eggs and a pregnancy rate of around 50% from 6 eggs. If it doesn't work though, sometimes we have extra embryos and sometimes we don't. So particularly in a situation where more than one child is potentially desired in the big picture, where embryo biopsy and gender determination may be something that you desire, then using a fresh donor is going to be much more advantageous than using eggs from an egg bank. And the reason is when we use a fresh donor, we stimulate the donor with the goal of trying to retrieve 15 or 20 eggs rather than just 6. So if you have more eggs, the advantage is that you have more eggs to choose from to fertilize. You have more embryos that are going to form. And even with a young donor who's under age 30, about 30% of embryos that form are just not going to be normal. So the benefit of a young, fresh donor is you have more eggs to choose from, more embryos, and most of the time we have extra embryos left over. So if you don't get pregnant in the first cycle, or you get pregnant and have a baby and want another one, 80% of the time we have embryos left over that are staying in cryo storage for future use. Whereas with eggs, we may or may not, we've gotten as few as 1 embryo, we've gotten as many as 4 from 6 eggs. But it really depends on how the fertilization process goes, as well as the thawing and the general quality of those eggs to start with. The second aspect of a male-male relationship, besides the source of the egg, is a gestational carrier. And the gestational carrier, similar to the egg donor, can either be an anonymous or a known person. We use some agencies that help recruit both egg donors and gestational carriers. A gestational carrier can be somebody you know, can be a family member, could be a friend. The important thing with all of these third-party reproduction issues are that it's very important to have at least one visit with a psychologist to review the whole concept of using third-party reproduction. And we screen both egg donors and gestational carriers, and the sperm bank screens sperm donors very carefully for genetic diseases, for infectious diseases, and for anything else that would potentially give us concern for a lower than ideal outcome. With gestational carriers, it's important to look at both the person as a whole. This is somebody you're going to need to deal with. It's a known situation, whereas egg and sperm are anonymous. A gestational carrier obviously is a known entity. They're going to be carrying your pregnancy, so you have to have a relationship with them during that time period. You don't have to be there for every office visit, but you want to be involved. You want to be concerned that they're getting good health care, that that you're supporting them, and that you appreciate what they're doing for you by carrying a pregnancy so you can have a family. And that's the whole thing in a nutshell. The big take-home message here is that as a fertility practice that's been around for 31 years now in Miami, we started our first donor egg program about 27 or 28 years ago. We were the first donor egg program in Florida. We have always had a very open and positive feeling for same-sex couples and their desire to have a family, and have worked with them for many years to make this successful. So the key here is, yes, it can happen. It requires a little bit of technology, as simple as donor insemination in a female-female couple, and a little more complex in a male-male relationship, in that we need both a source of eggs in the form of an egg donor, which can be fresh or frozen in origin, and obviously you need to have a relationship with a gestational carrier who's going to carry the pregnancy. So I hope that information was helpful, and if I can provide any additional information, let us know. If there are particular topics you want to hear about, please email us and give us the topics so we can adequately address them. And I wish you all a great afternoon and a great Pride Month, and wishing everybody the best. Take care and have a good day.